spinal cord injury or SCI is a devastating neurological condition resulting from damage to the spinal cord, leading to varying degrees of motor, sensory, and autonomic dysfunction. In this module, we'll explore the etiology, clinical presentation, diagnostic classification, and principles of rehabilitation for individuals with spinal cord injury. Starting with the anatomy and pathophysiology, the spinal cord is a cylindrical structure composed of nervous tissue that extends from the brainstem to approximately the level of L1, L2 vertebra in adults. It serves as the primary conduit for afferent sensory input and efferent motor output between the brain and peripheral nervous system. The cord is protected by the vertebral column and meninges. Trauma to the cord, either through direct insult or secondary compression, can lead to irreversible damage due to hemorrhage, ischemia, inflammation, and cellular apoptosis. The most common causes of spinal cord injury include motor vehicle collisions with around 38% of the causes, falls, this is particularly in elderly population, penetrating trauma, that includes the gunshots and stab wounds, then sports-related injuries including the axial loading and hyperflexion, then surgical or medical complications. The surgical and or medical complications are classified as iatrogenic injury. Then non-traumatic spinal cord injuries can result from tumors, that is cancerous growth, infections, e.g. epidural abscess, ischemia, or degenerative spinal disorders. So the major causes of spinal cord injury include the motor vehicle collisions, falls, penetrating trauma, sports-related injuries, surgical or medical complications. Then spinal cord injuries are classified as either complete or incomplete. For the complete, that is classified as Asia A, there is no motor or sensory function preserved in the sacral segments, that is S4, S5 region. Then the incomplete spinal cord injury, that is now from Asia B to D, some motor or sensory function is preserved below the level of lesion, including the sacral segments. The level of injury within the cervical, thoracic, lumbar, or sacral levels determine the extent of functional loss. Cervical injuries often result in tetraplegia. So this is where there is paralysis of both the upper and lower limbs, while thoracic and lumbar injuries typically cause varying degrees of paraplegia, that is paralysis of the lower limb, the lower extremity. So based on neurological classification, the Asia scale, the international standards for neurological classification of spinal cord injuries developed by the American Spinal Injury Association, that is Asia, is the most widely used system for addressing the severity of spinal cord injury. So there are grades from A to D, A, B, C, D, E. Then here the description. For Asia grade A, there is complete injury, no motor, or sensory function is preserved in the sacral segments S4, S5. Then for Asia grade B, the sensory is incomplete. Sensation is preserved below the level of lesion, including S4, S5. There is no motor function. Then for Asia grade C, this is motor incomplete. Motor function is preserved below neurological level, and more than half of the key muscles have a grade of power 3 or less. Then Asia grade D, this is motor incomplete. The motor function preserved with at least half of the key muscles with a power of 3 or more. So the power in Asia grade D starts from 3, then can range up to 5. Then for Asia grade E, this is a normal. Sensory and motor functions are normal. There's no loss. So the neurological level of injury is defined as the most caudal segment with intact and sensory bilateral functions bilateral. So after doing your dermatological assessment, the segment where you will find an intact motor and sensory functions on both sides, that is bilaterally, that is where we have the neurological level of injury. So on clinical presentation, the clinical manifestations of the spinal cord injuries depend on the level and completeness of injury. The common findings include paralysis or paresis below the level of injury. That is number 1, paralysis or paresis below the level of injury. Then you have sensory deficits including pain, temperature, proprioception, and vibration. Then loss of autonomic control affecting cardiovascular, respiratory, and gastrointestinal systems. Then bladder and bowel dysfunction. We have sexual dysfunction, then spasticity or flaccidity. This depends on the phase of injury and the segment that is affected. So those are the main clinical manifestations of SCI that depends on the level and completeness of injury. They can present with paralysis or paresis, sensory deficits, loss of autonomic control, bladder and bowel dysfunction, sexual dysfunction, spasticity or flaccidity. Complications may include the deep vein thrombosis, that is DVT, pressure ulcers, then there's heterotopic ossification, autonomic dysreflexia, and respiratory compromise. For the management and rehabilitation, acute management focuses on spinal stabilization, hemodynamic support, and prevention of secondary complications. Definitive treatments include surgical decompression and fixation when indicated, alongside high-dose corticosteroids in selected cases, though the use of methylprednisolone remains controversial. So the rehabilitative goals include preserve functional independence, optimize residual motor and sensory function, prevent secondary complications that include pressure injuries and contractures, train for activities of daily living, educate patients and caregivers on system management, educate patients and caregivers on self-management strategies. Then the therapeutic approaches in the rehab. Physical therapy remains one of the cornerstone in the management, and the interventions include mat exercises to enhance core stability and trunk control. There's wheelchair training for independent mobility. Then neuromuscular re-education, that is by using the PNF, that is proprioceptive neuromuscular facilitation patterns. Functional electrical stimulation, gait training with assistive devices or body weight supported systems in complete injuries. Then spasticity management, including stretching, positioning, and pharmacological agents. Occupational therapy focuses on upper limb function, activities of daily living, assistive device training, and environmental adaptation. So that is the therapeutic approach in the rehab. Then the prognosis and outcomes. The prognosis depends heavily on the level and completeness of injury. Patients with incomplete injuries, that is ASIA C or D, generally demonstrate better functional recovery than those with complete injuries. So those with incomplete injuries will demonstrate better functional recovery than those with complete lesions. Neuroplasticity, early rehabilitation, and patient motivation play critical roles in maximizing outcomes. Functional independence, though often redefined, is achievable. So spinal cord injuries present complex challenges requiring a multidisciplinary approach. Early intervention, accurate classification, and goal-oriented rehabilitation are crucial to improving quality of life and functional outcomes. As clinicians, understanding the neurophysiology and functional implications of spinal cord injuries allows us to better serve patients in their journey from injury to independence.